Oh, my name is Buitleir, and I'm a specialist registrar in the emergency department at Tallaght University Hospital. My presentation today is titled Multidisciplinary Simulation Aids Diagnosis and Management of Aortic Dissection through the Emergency Department at Tallaght University Hospital. Aortic dissection is an uncommon condition that, if missed, has catastrophic consequences. It is the most common cardiac surgical emergency, with an incidence of between 2 and 3 per 100,000 people per year. The classic signs of presentation have been described as sudden severe onset, substernal or chest pain radiating into the back. Classically, chest X-ray has been touted to show a widened mediastinum, and the patient may also show signs of syncope, heart or kidney failure, or signs of distal ischemia. However, the majority of those patients with a misdiagnosis present with atypical signs. Clinical exam, blood work, and X-ray are not enough to diagnose aortic dissection and can often be normal, with up to 20 to 40% of patients not displaying the classically taught widened mediastinum on chest X-ray. Atypical presentation and lack of awareness are key reasons for misdiagnosis. An early diagnosis is crucial, as it increases the success rates of surgery. Indeed, the mortality rate for patients with acute aortic dissection increases by 1% per hour in the first 48 hours from onset of symptoms if left untreated. So how do we identify these patients? Well, with great difficulty at times, as they can present as walk-ins with mild symptoms or with collapse. Leading factors in misdiagnosis are mild symptom presentation or symptom presentation leading to alternate diagnosis. Patients can present with sudden onset upper abdominal pain, migrating chest and abdominal pain, jaw pain, focal neurological findings, or pain that will suddenly improve or resolve entirely. The recently published UK Healthcare Safety Investigation Branch report from January 23rd, 2020 addressed the topic of missed aortic dissections and noted that up to 50% of the approximately 2,500 patients in the UK who develop an aortic dissection die each year before reaching specialist care. The main contributor to death is delayed diagnosis. The report states the two chief means of improving diagnosis are improving clinical awareness and increasing detection of the condition. The University Hospital of Bristol has reviewed this same issue in response to the deaths of 3 young people with atypical presentations of aortic dissection over an 18-month period in 2011. In response to their internal review, they have increased CT scanning of patients with suspected aortic dissection to approximately 300 per year, with an increase in the identification rate of 8 to 9 aortic dissections per year, and most importantly, no missed presentations since the institution of the program in 2011. The Bristol University Hospital approach emphasises emergency department history taking with attention toward 3 factors in particular. 1, sudden severe onset thunderclap chest or epigastric pain that can improve or even resolve with time. 2, maximal pain at onset, which can be transient or migratory and which may be associated with transient neurological signs. And 3, that while a patient may present with the classic high-risk signs of pulse deficit in either arm, chest pain, focal neurological deficit, new aortic murmur, or hypotension, that the absence of any of these signs does not exclude the diagnosis of the aortic dissection. Following a case of missed aortic dissection in our own institution, the emergency department, in conjunction with the surgical service and radiology department, resolved to institute a pathway that would result in better detection of aortic dissection through increased awareness among healthcare practitioners and greater access to imaging. As part of this pilot program, we designed a simulation teaching session with the specific goals of raising awareness among staff working in the emergency department of aortic dissection as a diagnosis, as well as to practice smoother transfer of potential patients to imaging and, if necessary, then on to definitive care with the cardiothoracics team at St. James's Hospital in another institution to our own. This program was delivered to all emergency department staff on a rotating 3-monthly basis, with a didactic learning session also being delivered in a separate education session to the simulation. The simulation as designed was a multidisciplinary event comprising nursing and medical staff from the emergency department, as well as radiology and surgical staff. In order to raise awareness through all the stages of the emergency department care pathway, a mock patient, role played by a member of the nursing staff, was registered and triaged as a 52-year-old male, self-referral, with sudden onset severe chest pain that had begun at 6 a.m, was now resolved, and he was pain-free at presentation. On recognition of aortic root pain as a trigger to escalating the care of such patients, he would then be transferred appropriately to a resus bay due to the suspicion of aortic dissection as a cause for his symptoms. The explicit learning goals of the simulation were to familiarise the ED staff with the typical presentation of thoracic aortic dissection, with the hospital guideline, and with the priorities for management and organisation of patient disposition to either cardiothoracics or cardiology. Further objectives were on prioritising tasks, calling for help early, and anticipating and planning for potential complications in the care of the patient should they arise. Specific medical objectives were taking an appropriate approach to investigations and management of a patient presenting with sudden onset severe chest pain in line with the previously delivered teaching sessions and information campaign on aortic dissection, and also included when to consider aortic dissection as a diagnosis and making the correct imaging request for the queried dissection. Recognition of the importance and urgency of transfer to both imaging and disposition was a key modifier for those involved in the simulation, as was the need to explain the diagnosis to the simulated patient. Practical skills were also utilised via point-of-care ultrasound of the aorta and mock images supplied to support aortic dissection as the most likely diagnosis, even pre-CT. Since the establishment of this pathway, of which simulation training is a key component, Tallaght University Hospital's scanning for aortic dissection has increased significantly, with 4 de novo aortic dissections having been detected, as well as 3 other emergent conditions specifically as a result of this dedicated programme. Most importantly, there have been no missed dissections since initiation of the pathway. This was only achievable due to the educational and clinical dedication from our emergency department programme and also the support from our radiology programme. Thank you.